This is the advanced pulmonary exam. So if you used your basic exam skills and listened to the lungs, percussed lungs, and you may have found some abnormalities. Parts of these exams that you'll do here can help to confirm what is the cause of those abnormalities. In other cases, your basic exam may have been completely normal, and you want to confirm and make sure that there is not an additional problem. And so again, these exams can help with that. Now the very first part of the exam to perform is called vocal resonance. And vocal resonance is looking for a change in the way somebody's voice sounds transmitted through the lungs, and this will change based on whether or not a patient has consolidation, such as from a pneumonia, or if there's presence of pleural effusion or pneumothorax. Vocal resonance is the technique that sound, while traveling through spaces such as alveoli, sounds a certain way, but then if you have consolidation, such as fluid is, the alveoli are filled with fluid, then the sound will change. And if you have a patient say 99, and you listen over the trachea, here I'll demonstrate that. So I'll listen here, now say 99.
99.
All right, that's a fairly distinct sound. Whereas if I'm listening over a normal lung, the sound is indistinct. And so what I'm looking for is there an area where the sound is much more distinct in the lung, which could indicate consolidation? Now, in the case of pleural effusion or pneumothorax, the sound is even further away, even harder to hear than what's in the normal lungs. So you're looking for sound is somewhat diffuse, hard to hear, that's normal. Sound is very distinct, that's consolidation. Sound is much farther away, more distant, more difficult to hear, and that's pleural effusion or pneumothorax. So I'll demonstrate how I'll listen to different parts of the lungs here. Now, Paul, could you turn this way? And you can lower your gown. Thank you. Now I'll listen here over the left upper lobe and say, Paul, can you say 99?
99.
And repeat that here, right
99.
upper lobe. And right lower lobe.
99.
Left lower lobe.
99.
Again, left lower lobe.
99.
And right lower lobe.
99.
As I'm listening, I'm comparing what the sound sounds like in one lobe compared to the other lobe to ensure that it sounds all the same throughout. Now, if I had, in a female patient, I also want to listen to the right middle lobe, but in this case under the axilla, so I'll demonstrate that. You can raise your gown here. And now if you can lift your arm, and I'll listen under here, and again say 99.
99.
All right, so that's the area of the right middle lobe. Now you can turn the other way, and you can lower your gown again. And now I'll listen in the front. Now, as you've noticed, I've had the patient move back and forth, which is for purposes of videotaping here. Clearly, when you're listening to patients either in PDS or in the office, you yourself would move around the patient as opposed to having the patient move. But in this case, now I'll demonstrate the front for vocal resonance. Say 99.
99.
And again.
99.
All right, I've listened to left upper, right upper lobe. And in the male patient, I can listen to right middle lobe right here.
99.
All right. So your right middle lobe extending in this area and then down over into the axilla, you use whatever is better for your patient in terms of listening to that right middle lobe. And as you know, of course, on the left side, left upper lobe is in this area, and then left lower lobe right here without there being a left middle lobe. All right, so as I've listened to the patient's lungs in all these areas, I'll demonstrate the next test that I would perform if I found increased vocal resonance. Now if you can turn back the other way. And I'll demonstrate this for having heard increased vocal resonance in the left lower lobe on this side. Now, when you hear increased vocal resonance, the other term that you'll sometimes hear for this is bronchophony, meaning that it sounds like bronchial breath sounds, like what you hear over the trachea and upper bronchial regions. So let's say I've heard that there's increased vocal resonance or bronchophony in this area. Then I want to perform the next test, which is egophony. And normally when I ask the patient to say E, it'll sound like E, again, somewhat indistinct in the normal lung. But if there is consolidation, when I ask the patient to say E, it'll sound like A. So I'm going to check in this area. Now can you say E?
E,
And again,
E,
and again.
E,
Now I want to compare this with normal lung, so can you say E over here?
E,
And again,
E,
and again.
E.
So egophony will help to confirm whether or not there may be an area of consolidation. Now, the next test is whispered pectoriloquy, also very helpful in confirming whether there is consolidation. And in this case, I'll ask the patient to whisper 99, and I'll use this area of the left lower lobe as the example. Can you whisper 99? And again, and again. Now, as I'm listening to the patient whisper, if this is consolidation, that'll sound very distinct. I'll be able to hear 99 very well, as opposed to normal lung, where it again is indistinct. So I'll compare this side where I think there may be consolidation with the right lower lobe or another part of the lung that I think is normal. Now, whisper 99, and again, and again. There isn't any magic to performing right lower lobe to left lower lobe. It's more the issue is confirming that this lung is abnormal and hearing 99 more distinctly compared with other parts of the lungs where there's no consolidation. Now I'll move to a test that'll help you to confirm whether or not your patient has COPD. In a normal situation, the diaphragm should move up and down with respiration. And as I ask a patient to take in a deep breath, the lung should move, or the lung and diaphragm should move distinctly enough that I can sense that difference through percussion. If I have a patient who has COPD, the lungs, or emphysema, the lungs, as you know, are maximally expanded. The chest wall is maximally expanded, and I will not be able to see any movement of the diaphragm as the patient takes in a breath. So one of the tests I can do here is called diaphragmatic excursion, seeing if there's any movement of the diaphragm with deep inspiration. So what I'll do first is tap and find where is Paul's diaphragm. And right there, this is lung. Here's below the diaphragm. I'll find that spot where it changes. Right there. Now, Paul, can you take in a deep breath and hold it? And I'll tap further till I find the diaphragm here. So the diaphragm moved from this area to this. You can breathe normally again as Paul took in a deep breath. And that's a normal amount of diaphragmatic excursion. I can see there's clear movement. Now, I checked on the left side. I also want to check on the right side. So I'll do the same thing. All right, there's the diaphragm right there. Normal lung below the diaphragm. Now take in a deep breath again and hold it. And I can see there's been some movement of the diaphragm, again, a little bit less on the right than the left. You can breathe normally. But you see that there's some movement of the diaphragm as Paul has taken in a deep breath, as showing that the diaphragms are not maximally expanded as I would see in COPD. So this is normal diaphragmatic excursion on both sides. Now, if Paul had COPD, and I would find the lower edge of the diaphragm here, right there, and now take in a big deep breath, and if I check again, I find there's no movement of the diaphragm consistent with the diaphragms having been maximally expanded. You can breathe normally again. Now I'll do the same thing on the right side. Okay, right there is the edge of the diaphragm. Now take in a deep breath again. All right, and no change in the diaphragm. You can breathe normally again, showing that there has not been movement of the diaphragm on that side as well. All right, now you can turn towards the front here. Now, one last test can help to confirm whether a patient may have asthma or COPD, and this is forced expiration. This is checking and making sure that the patient has been able to breathe out quickly as much air as he possibly can. If someone has asthma or COPD, that expiratory phase is prolonged and slow and sometimes is associated with wheezes. So first, I'll have Paul take in a deep breath and then blow it out hard and fast. Good. And as you see, the air came out pretty quickly. I didn't hear any wheezes, but I can also listen over the trachea. Now take in a breath again and blow out, air out hard and fast. And I can also make sure that I don't hear any wheezes over the trachea as the patient is exhaling. If I had a patient with COPD or asthma, when I would ask him to exhale, that'll be slower, more prolonged, and I can sometimes hear wheezes. So Paul, if you can take in a deep breath, this will be the example. And now exhale. All right, and Paul cannot blow out air as quickly as normally. And I can also take in a deep breath and blow out again, and I can listen and see if I hear any wheezes at that time. All right. Now that concludes the advanced pulmonary exam, and always remember, of course, when your exam is completed, you can place your gown back on. If you like, may I help you with that? All right, and so always making sure to finish your exam by replacing the drapes or the gowns that you have moved in order to perform the exam.